So I want to add my thanks to Kobe and Lori for organizing this wonderful meeting. It's really great to be here. So a lot of the slides that I have repeat some of the slides and data that you've already heard. So I'm going to just try and show them, but with a little bit of a different bent. So the topic of my talk is that 5 ARIs will not be used for chemoprevention in 10 to 20 years, largely because they're preventing cancers that probably don't need to be prevented and not preventing the cancers that we all know need to be identified and treated, perhaps even more aggressively. So you've already seen these slides from PCPT showing a reduction of about 23% largely in low-risk cancers. But as you know, there was really no statistically significant difference in the diagnosis of Gleason 7 cancers, and there was actually an increased diagnosis of particularly high-grade cancers in men on finasteride. The same thing was actually found with the REDUCE trial. It was a different population, but again, the bulk of the reduction in the risk of developing prostate cancer was in the low-risk population. There was no change in the development of prostate cancer in the Gleason 7 population, and there again was a not statistically significant, but a trend towards an increasing risk of developing Gleason 8 through 10 cancer while on the REDUCE trial. And if you actually look at the comparison of relative risks of cancer detection in both of these trials, you can actually see that in both trials there was an increased relative risk of developing prostate cancer, Gleason grade 8 through 10 in both populations, no change, a relative risk of essentially 1 for Gleason 7 through 10, and all of the reduction was found in low-grade cancers, which, as you've heard from Dr. Klotz and others, perhaps are the ones that we are over-treating. And then Neil just showed his study, REDEEM, and I think that it basically shows exactly the same thing. The reduction was, again, in Gleason 6 cancers. There was a reduction in the volume of those cancers, but there was actually no change in progression of cancers during active surveillance from Gleason 6 to Gleason 7. So again, I think all three studies show that 5 ARIs, while they may have a role in preventing low-risk cancer, have no role in preventing high-risk cancer or intermediate-risk cancer, and perhaps may even increase the risk of developing these cancers, which are the ones that we really want to be preventing. And then there's even some debate about whether ARIs really even reduce the risk of low-risk cancer, because if you look at all of the patients on those studies, or most of them, had biopsies that were indicated in the trial. So they were not done the way that we actually biopsy patients in the clinic, which is for-cause biopsy, a rising PSA, or an abnormal DRE. And if you actually look at the percentage of cancers diagnosed in both of these trials in terms of for-cause biopsies, there was actually no difference in diagnosis. So one could even argue that there really is no significant reduction in the diagnosis of prostate cancer in the real world, and it was just shown in these trials in essentially a false world where biopsies are done routinely because of mandates of a clinical trial. And then there have been a number of, there's been a large discussion about this whole issue of risk of high-risk cancer, and the FDA actually rejected Dutasteride as primary prevention for prostate cancer because they did a number of post-hoc analyses addressing this question as to whether or not there's an increased risk, increased diagnosis of high-risk cancer simply because you're decreasing prostate volume. That leads to an increased likelihood of identifying high-risk cancers within the prostate. And I'm not a statistician, but quite a number of different models were done, and they did not hold up as supporting this idea. So they rejected Dutasteride because of this concern about high-risk cancer, and I think also because they felt that the risk reduction of low-risk cancer perhaps doesn't have any long-term impact, or certainly hasn't been shown to have any long-term impact on mortality from prostate cancer. So summarizing these trials, Dutasteride and finasteride reduced the incidence of prostate cancer by 22% at 4 and 7 years. The risk reduction is exclusively in Gleason 6 cancers. There's no change in Gleason 7, and there's an increased incidence of Gleason 8 through 10 cancers in both studies. So while we may be reducing the incidence of indolent cancers, we're not really, and that may help us address the concept of overdiagnosis and overtreatment, we're not really reducing the risk of cancers that are likely to progress and cause metastasis and death from prostate cancer. So in 2012, is this good enough? And I would argue that it's probably not. They may be valuable in reducing prostate cancer overtreatment. Less detection of low-risk disease may mean less treatment of prostate cancer, even with the caveats of no change in for-cause biopsies. But whether or not this is actually justified is still unclear. There's an increased relative risk of high-risk disease. There's a risk of decreased detection of high-risk disease simply because PSA goes down with 5-ARIs, and that may actually mask high-risk cancers in a certain percentage of men. This is Pat Walsh's argument against the use of 5-ARIs. I think one could debate this. There's certainly expense, and as Neil showed, there are minor side effects associated with these drugs. And there's actually no really long-term data on the effects on risk of progression of those patients with high-risk cancer. So now looking forward to 2022. The major benefit of 5-ARIs, again, is reduction in cancer detection and overtreatment. However, and I think in 10 years, and I think you've heard this from Dr. Klein, Dr. Fleschner, and others, we won't have this problem that we have right now of overdiagnosis and overtreatment because we will find other ways to address them. We will improve our diagnostic accuracy through, as you heard a little bit last night, the use of MRI and other biopsy techniques that can actually pinpoint lesions within the prostate and reduce the risk of underdiagnosis of high-risk cancer and overdiagnosis of low-risk cancers. And then there will be increased molecular classification of tumors, or so-called personalized or precision medicine, to help us identify which cancers need treatment and which ones don't. So the problem of overtreatment will be less of a problem, and so the use of 5-ARIs will decrease or lose their one justification in my mind. Also, we'll have reduced side effects of treatment. You've heard a little bit about focal therapy. You'll hear about it more later this morning by Dr. Beldrigan and others. And I think we'll have continued improvements for those patients who need treatment in terms of reducing morbidity. So I'm just going to show two examples of how we can actually address the problem of overdiagnosis and overtreatment, and therefore reduce the need for the use of 5-ARIs. So one is by more accurate diagnosis using targeted biopsy approaches. This was a patient who had a microfocus of Gleason 6 on his biopsy. He was considered to be an active surveillance candidate, and as we do at UCLA, we obtain a multiparametric MRI on all of these patients prior to entry into active surveillance. We identified here a lesion, a grade 4 lesion in the anterior part of the prostate, shown by increased perfusion and decreased diffusion of this area. This was then biopsied using the Artemis device, so using MRI fusion, and found and confirmed a Gleason 8 cancer, which was then removed surgically. And so one can definitely use MRI right now as a way to reduce the problem of overtreatment. We looked retrospectively at a cohort of patients that we did robotic prostatectomies on, and we looked to see whether or not MRI retrospectively would have reduced the incidence of overtreatment or overdiagnosis in these patients. We used a simple cutoff for looking at MR. We used diffusion. I think Dr. Tawari mentioned this last night, but a simple cutoff of less than 850 as a measurement of diffusion was considered to be a grade 4 or 5 lesion on MRI, likely to be a high-risk cancer, and considered to be inappropriate for active surveillance, whereas anything greater than 850 was considered to be appropriate. And all we did in the studies would compare the use of the traditional Epstein criteria for low-risk disease and compare that to the use of both Epstein criteria and MRI criteria, diffusion as a single parameter, to determine whether or not we could improve the diagnostic accuracy of biopsy. And so what we found is that using Epstein criteria alone, we all know that if you use this alone, that there's a risk of underdiagnosis of prostate cancer. That is, 30% of those patients will turn out to have higher risk disease, Gleason 7 or higher, on their final radical prostatectomy. And this was confirmed here. And in terms of correctly calling significant disease, that is, Gleason 7 or higher disease, it was 82% accurate. But if you used MRI combined with the Epstein criteria, you could actually decrease this chance of underdiagnosis, and when you could accurately diagnose all of the high-grade cancers, about 95% of them, using a combination of both Epstein criteria and MRI. So I think this is going to get better and better. We have new ways of actually looking at diffusion. There are new parameters and new spectroscopic techniques being used in MRI. So I can imagine 10 years from now, this technique, although somewhat imperfect right now, is really going to decrease the need for the use of 5-ARIs. And then finally, two slides that Dr. Klein showed is that we're really starting to understand the genetics and the molecular biology of prostate cancer. This is simply a global look at the different gene fusions and chromosomal rearrangements in prostate cancer so that we can start to actually biopsy accurately, target lesions, and then classify them at the molecular level so we can determine much better which ones need treatment and which ones don't. And then you can actually look at the genetic changes in terms of mutations as well, so we can look at gene fusions and mutations. And this was really a very powerful paper just came out by Arul Chinayan's group in Michigan, looking at the entire landscape of lethal prostate cancer and looking at the genetic changes in these cancers so that we can really start to identify genetic changes that can actually be targeted, but also can be used as predictive markers of which cancers need treatment. So in summary, 5-ARIs will cease to be used in 10 years. They're not even used very much right now because although the evidence shows that they decrease the risk of development of prostate cancer or diagnosis of prostate cancer, that decreased risk is in low-risk cancers, and we will have, and have right now, and we'll have better ways to identify those tumors in the future and avoid treatment rather than putting people through the risk of an increased risk of high-risk cancer with these drugs. Thanks very much.